You've probably seen me quite a bit today. I gave a similar talk to this at the AMSEC conference this year, so I thought I would share with THI. So today I'm going to be speaking about the pathophysiology of myocardial injury and cardioplegia. I'm a full-time perfusionist here at CHI St. Luke's, and I'm the perfusion research coordinator for Texas Heart School of Perfusion. So what are the goals of cardiac surgery and the myocardial protection? For the surgeon, it's pretty simple. They want a quiet operative field and low early mortality, having the necessary time to perform a perfect surgical repair. Most surgeons believe current myocardial protection strategies are adequate, and as most of these patients survive the surgery. So what are the clinical indicators of myocardial injury? Despite surgical advances, the perioperative myocardial damage remains the most common cause of morbidity and death following a technically successful cardiac operation. 90% of patients who do not survive the perioperative period show myocardial necrosis. Patients suffering from intraoperative myocardial damage may go on to develop late myocardial fibrosis and congestive heart failure. But what causes this myocardial injury? The effect of hyperkalemia and prolonged myocardial membrane depolarization to a minus 50 millivolts and ischemia reperfusion injury can lead to myocardial injury. The sodium entry through the window current induces a reversal of the sodium-calcium exchanger with the entry of calcium into the cell. Regional ischemia and metabolic acidosis can further impact calcium loading. Increases in intracellular acidosis activates the sodium acid exchanger, and the sodium acid exchanger induces further activation of the sodium-calcium exchanger, exacerbating calcium overload in the myocyte. The entire cascade can induce depletion of ATP, generation of reactive oxygen species, cell apoptosis, and arrhythmias, and loss of contractility. So the ischemia reperfusion injury mediators that we most commonly follow in research, neutrophil activation, ROSs, inflammation, calcium loading, and pH restoration occur mostly from the ischemia reperfusion injury complex process, which involves several interrelated factors, including a decrease in cellular ATP, accumulation of hydrogen ions, calcium overload, and ROSs. These factors collectively promote cellular injury and subsequent myocardial death. During acute myocardial ischemia, the absence of oxygen switches cellular metabolism from aerobic to anaerobic respiration, resulting in the production of lactate and a drop in the intracellular pH. This increases that sodium acid exchanger to extrude acid and results in sodium loading, which then activates that sodium-calcium exchanger to push out the sodium, which causes calcium overload. During reperfusion, those reactive oxygen species are generated by oxidative stress in endothelial cells and myocytes and neutrophils. This damages the cell membrane by lipid peroxidation, induces enzyme denaturation, and causes direct oxidative stress to the DNA. Reperfusion and reactivation of the sodium acid exchanger results in washout of lactic acid. Several hours after the onset of myocardial reperfusion, neutrophils accumulate in the infarcted myocardial tissue in response to the release of those chemotactic ROSs, cytokines, and activated complement. There are some non-pharmacologic protective approaches out there prior to bypass. One is ischemic preconditioning. It's a therapeutic approach where they apply short episodes of ischemia to protect the myocardium from that big heart attack. Then there's one that they apply post-conditioning. So after the reperfusion injury, they apply 3 more slow ischemia reflow 5-minute insults, and that slows down the washout of the lactic acid, and the regulation of pH takes longer, and it seems to be protective. And lastly, it's called remote ischemic conditioning. This process is a therapeutic intervention that they apply away from the heart. They put a pressure cuff on the upper arm or the leg, and they do 5-minute ischemia, induce ischemia in that limb for 5 minutes and release. And then after releasing, the last time they do the surgery, and it's been shown to reduce myocardial injury and have more survival of myocardial cells. But we're perfusionists, so what do? We do protective ischemia, which under bypass, we apply a cross clamp and give some type of cardioplegia. There are crystalloid cardioplegias, such as the St. Thomas, Legisol, and Del Nido. They have extracellular levels of sodium, which are higher, but low calcium levels. A potassium to cause a depolarizing arrest. These solutions in general are given about every 20 minutes. They have a buffer, and the St. Thomas solution is a little different that it has procaine. So if you give a lot of it at high doses, it can cause seizures. And then there are the other crystalloid. This is straight crystalloid cardioplegia. The custodial HTK, Rex Schneider solution, has intracellular levels of sodium and very low calcium. Histidine, which is the buffer that exists in blood, is a great oxygen-free radical scavenger, as well as it buffers the blood even at very low pHs as low as 6.0. Tryptophan, which helps stabilize the membrane of the cells. Glutaraldehyde, which is an intermediate of the Krebs cycle. Potassium for a depolarizing arrest. This cardioplegia can be given as a one-time dose, and it gives you 2 to 3 hours of quiet heart for the surgery. Blood cardioplegia is a mixture of a crystalloid with blood as the carrier. Blood gives the benefit of oxygen carrying capacity. It has natural buffering agents, antioxidants, free radical scavengers, and then other additives are added, such as some type of buffer, whether it be bicarb or THAM, a citrate solution to chelate the calcium, and they keep it hyperosmolar to prevent edema in the heart. And this was just a study showing the differences between whole blood cardioplegia and a Del Nido solution, and the differences of giving a 4-to-1 versus the 1-to-4 solution and the amount of potassium that you're giving. This is protective ischemia with blood cardioplegia, which is not very prevalent in the United States. It's called the ALM solution. It's the adenosine, lidocaine, magnesium solution. This is also mixed with blood, but the mechanism of causing the rest, the adenosine opens potassium channel opener, and it keeps the sarcolemma open, and it arrests the heart at -80 versus that -50, much more close to its natural baseline. So it's a polarizing arrest, not a depolarizing arrest. Lidocaine helps block the fast sodium channel, the upswing for your the start of the electrical pulse, and magnesium to compete with calcium. So the benefits of adenosine, as well as opening that potassium channel opener, it's also an antiarrhythmic, and it helps decrease coronary artery vascular resistance, and it's an antispasmodic. So there was this study, which is a randomized human trial comparing microplegia using the ALM solution with a standard Buckberg solution of 4-to-1 with blood. The ALM solution was shown to have better troponin levels, substantially lower at 6, 12, and 48 hours post-surgery, as well as reduction in lactate. These are good measurements of actual muscle injury, and that it seems that the ALM solution is a little more protective in this group. This is the some STS database information from 2022. This is looking at from 2010 to 2021, the number of total cases in adults. This is adults only. And it shows that there has been a steady increase in cardiac procedures from 2010 through 2021. There was a slight decrease in cases from 2019 to the beginning of 2021, just due to the the restrictions of the COVID-19 pandemic reduced overall cardiac cases to emergencies only, so there was a national decrease. But the overall trend has been more cardiac surgery is needed. There has been an increase in on-pump CABGs in 2021 than off-pump. The increase in, there is a decrease in SAVR cases compared to, because of the influx of TAVR cases taking over, but the mitral valve cases seem to be very similar. Of these selected outcomes, I'm just looking at 2020 to 2021. The operative mortality, if you look across the board at new onset atrial fibrillation, it is, has remained constant from 2020 to 2021. About 30% of all the cases report new onset atrial fibrillation. That's an indicator that there is myocardial damage. The atria are more sensitive to high potassium than the ventricles. So an atrial AFib is an indicator that we may not be protecting the atria as well, and that deep muscle of the ventricle may not, I'll be showing some wall motion abnormalities occur as well. So in the US, whole blood cardioplegia is majority. 85% of people use a chemical cardioplegia to arrest the heart versus fibrillatory arrest. Of those who use chemical cardioplegia, 62% use blood cardioplegia, 26% use crystalloid only, and 11 or almost 12% use a combination of blood and crystalloid cardioplegia, switching back and forth. Benefits of blood cardioplegia has the added advantage of increasing the oxygen carry capacity due to hemoglobin. It's also a better buffer capacity because of the histidine. You can deliver nutrients that are present naturally in blood to help aid in the anaerobic substrates that are needed. It's a free oxygen radical scavenger. It aids in oncotic load as well as improves the acidotic environment during reperfusion as you give the blood. What are the current markers of myocardial protection? In most clinical studies, they're measuring things like hospital and ICU length of stay, arrhythmias, inotropes, use of intra-aortic balloon pumps, and 30-day mortality. None of those metrics measure muscle injury. So if we're concerned that our job is to protect the heart, yes, the surgeon's fixing the heart, but we're supposed to be protecting it while he's working on it. Better markers that we should consider following are cardiac enzyme levels. The CKMB, creatinine kinase levels, are a good indicator. It's been shown with a risk index. If your risk index is greater than 2.5 to 3, you're going to develop you're developing severe heart damage versus a lower amount from 2.5 to 3. It's mild, indicator of mild heart damage. And even small changes are very relevant. And troponin I, which is a very good indicator of heart damage, normal troponin levels should be very low, 0 to 0.4. Anything greater than 0.4 nanograms per ml are considered high. So having high, unless you started because you had high troponins going into the surgery, developing high troponins as you come out of cardiac surgery is an indicator that there's some muscle damage going on. And then postoperative septal wall motion. The RV and the LV are separated by the septum. Oh, here it is. So the septum, it's a subendocardial structure. It's more vulnerable to inadequate myocardial protection and is easily seen on echocardiogram, and its dysfunction indicates muscle injury. The septal dysfunction is common. It happens in 40 to 80% of the cardiac surgical patients. The septum occupies 35 to 40% of the total ventricular muscle mass, making it much more massive than the right ventricle free wall, and it's 50% of the left ventricle free wall. So any abnormality in that wall motion is going to be a good indicator that there is some myocardial injury that was not prevented during the surgery. And that's also, it wasn't there before. These are things that are happening post recovery after the clamp comes off. So now we're going to talk about some solutions and techniques. The hot shot and the warm induction, which a lot of was started by Dr. Buckberg So Kirkland showed global myocardial ischemia can be avoided or minimized by substituting a brief 3 to 5 minute warm 37-degree blood cardioplegia solution, that hot shot, during the initial phase of reperfusion before you release the aortic cross clamp. He compared over 3,800 patients receiving cold blood cardioplegia alone to almost 2,400 patients receiving warm cardioplegia reperfusate, the hot shot, before the clamp was released, and demonstrated that there's a significant decrease in mortality when you use a hot shot. Also, a warm induction dose, a brief infusion of warm oxygenated cardioplegia solution can be used as a form of active resuscitation for an energy depleted ischemic heart that must undergo a very long cross clamp time. Normothermia optimizes the rate of cellular repair and the enrichment with amino acid precursors of the Krebs cycle immediates, such as aspartate and glutamate, improve oxygen utilization capacity. Therefore, it helps repay that energy debt prior to the cold ischemic arrest. So the cardioplegia route, we normally give cardioplegia antegrade or retrograde, whether it's through osteocannulas to protect the heart. But with normal non-stenotic coronary arteries, antegrade protects both sides of the heart very well. But that's not true in the presence of coronary artery occlusion or significant stenosis. Antegrade delivery is poorly distributed to the areas of stenosis, and flow is directed away from the vulnerable subendocardial muscle. Retrograde cardioplegia is directed preferentially towards those subendocardial muscles, despite occlusion of the arterial vessel supplying that jeopardized area. But it results in inconsistent RV and septal protection because of the placement of that balloon catheter. Clinical observations suggest that antegrade and retrograde cardioplegia supply different vascular beds. As glucose and oxygen uptake increase and lactate washout occurs when switching from one modality to the other. But a combination of antegrade and retrograde cardioplegia may be the only way to perfuse an area of the myocardium in the presence of significant coronary artery disease, or when antegrade perfusion is more difficult, such as during a mitral valve or aortic valve surgery. Most surgeons use intermittent cardioplegia to have a bloodless surgical field. Continuous blood cardioplegia was usually given warm to avoid the problems of hypothermia. Keeping the heart warm increases the metabolism of the muscle, meaning that inadequate perfusion or interruptions in cardioplegia flow was not well tolerated. A continuous cold cardioplegia solution, when visualization was not impaired, significantly improved myocardial protection, especially when done during long cardioplegia or long surgeries. So the effect of cooling blood cardioplegia on viscosity. This is a study by Ekman. In the top box, the shape of these curves relates blood viscosity to shear rate, and it demonstrates that blood exhibits non-Newtonian behavior at shear rates that are very slow, less than 45 seconds, and that as blood viscosity increases, the shear rate decreases. So blood is a shear thinning. At slower rates, it's going to have higher hematocrits. So when you have slower flows, the effect of the blood speed will be affecting your shear rate and your viscosity. The second graph here, it's an independent effect of temperature on blood viscosity. It demonstrates that the relationship between temperature and blood viscosity is nonlinear. In general, viscosity increases as a function of decreasing temperature. For every 1 degree you decrease temperature, you increase blood viscosity by 2%. And so you get a steep incline in viscosity when you get in ranges between 15 to 0. So as you're cooling, and those are the temperatures we're giving our Cardioplegia out, we're getting much higher viscosity from that blood we're delivering. So giving a diluted Cardioplegia system with a hematocrit around 24, you're going to still be at lower viscosity rates, which you may want to have a little thinner blood. And lastly, the hemodilution, the blood viscosity would also be expected to be an important determiner in tissue perfusion in the clinical situation of hypothermic low flow during cardiac bypass. In this situation, low flow results in low shear rates, would magnify the effect of hypothermia-induced hyperviscosity in the microcirculation. So if you're going to make the tissue really cold, you don't want to have a hyperviscous, high hematocrit cardioplegia going into that. So in summary, blood cardioplegia is widely used in the US, and it's given at various concentrations and formulas. The integrated cardioplegia strategy may aid in reducing myocardial damage, both antegrade and retrograde. Monitoring postoperative enzyme release and septal function is critical in diagnosing injured myocardium. And there is no gold standard of the perfect cardioplegia solution. Blood is simply the vehicle to deliver the cardioplegia, and the temperature of the solution is important as a manner of how it's delivered. That's